Good morning. Again, I'm Brenda Williams. I'm the nursing care manager of 2 West, so the pre and post cath lab. It's also outpatient cardiac. I'm the chest pain coordinator, and I'm also over our teles, our telemetry packs that get put on our patients throughout the hospital. I'm over that department as well. We'll get started with our EMS run. This particular run ended up being a 38-year-old female with a complaint of chest pain. They received the call at 6:22 that morning. By 6:39, they arrived to the patient. Patient was sitting in her dining room chair in care of E6 personnel, alert and oriented ×3. Patient stated she was awoken from sleep at 5:30 with sudden onset of chest pain. She had a history of an MI 3 years prior. She reported she could not locate her nitro spray. She rated her pain a 10 out of 10, sharp in center of her chest and radiating towards her throat. Pain was worse on deep inhalation. She was very nauseated. By 6:43, vital signs were obtained. They got 136/88, a heart rate of 100, respirations of 18, blood sugar of 151. By 6:47, they inserted 22 gauge IV and given 500 milliliters of normal saline. This was inserted into her left forearm. Also 6:47, they were getting the 12 lead, ST elevation on leads 3 and AVF with ST depression on leads V1 and V2, and they transmitted this to Union Hospital. By 6:49, they'd given 324 of aspirin PO. They said they'd held nitro due to her blood pressure and location of the ST elevation. 6:53, they obtained some more vital signs, 132/90, a heart rate of 120, and respirators of 20. By 6:55, they arrived and transferred care to Union ED. They crossed by 7:59, balloon catheter across the target lesion. At 8:20, it was reported 99% stenosis in proximal segment of the right coronary artery at site of the previous stent with very complex morphology of the lesion. They successfully stented with a drug-eluting stent. The pre-hospital EKG to balloon time was 72 minutes. Door to balloon time was 64 minutes. Patient was admitted to ICU and discharged 3 days later. She ended up having a couple other blockages. She was another doctor's patient. She, of course, had the doctor that she had coming in to have her cath, and so she had follow-up and came in for some more care. A lot of history. She was a smoker, very non-compliant. So, gosh, look at that, 38 years old, it's awfully young to having your second heart attack. Door to balloon times, I've got the numbers for 2019. I've not gotten any for 2020 yet, but we were, as you can see, 100% across the board last year. So we're looking pretty good. And thank you for all that you do. Thanks.
Hi guys. Good morning. I think I know almost everybody in the room. For those of you who don't know me, my name is Jackie Martin. I am the trauma program manager here at Union. Why are we not? Are we moving? Okay. So I picked a couple cases. Both of these cases I thought were really good, really good. Oh, I'm a pacer. I'm very nailing my toes down. One of the medics is here, so I'm going to say kudos. I'm going to call you out, Chuck, because I'm telling you what, you were one of the most creative medics I've ever met. So Chuck's, I thought he was just really creative in the way he handled this patient. The other one I thought did a really awesome job of describing this patient so that we could get a better picture, because it took us some days. It's one of Julie's medics. I was kind of hoping he'd be here today. It took us a couple of days to finally put all the pieces together. So for those of you who don't know, I like interaction, which means you get to talk too. Okay, so as we're going through this case, if you see something, talk about it. Let's talk it through, and then at the end I'll give you an opportunity for that. So this one was an altered mental status, dispatched for altered mental status. So the 911 call came at 15:13, dispatched at 15:13, en route at 15:13. So middle of the day, it's usually easy to happen. On scene at 15:20 and left scene at 15:42, and then here in the ER at 16:09. So really good times there. 911 call to arrival on scene was 7, on scene for 22. I'll give you 2 minutes. Your goal is 20. Just a little reminder on that. I'm seeing some longer scene times with no explanation. So 20 is your goal, right? If you have long scene times, just tell me why, okay? Maybe they were in the back bedroom. Maybe you had to do a little care. Maybe it was a rough IV stick. Maybe they were just being a normal patient. 911 call to arrival in ED was 56 minutes, so good times. So the patient was with fire rescue and PD when medics got there. He was trying to put his house key into, I'll loosely call it an apartment door. It used to be an old hotel. It's been converted to an apartment. Okay, you get the picture. But that was definitely not where he lived. He actually lived way across town. EMS notes that he had coagulated blood on his face and throughout his scalp. So that was really important. Later, we figured that out. So there was no active bleeding. He was very, very confused, okay? He could tell him who he was, and that was about it. He couldn't tell him what had been going on. He kept telling him he was dizzy. He was a little tacky on the monitor. The medic notes in there that he had some minor scalp plaques. He had one over his ear, two in his occiput. So definitely some head injury going on there. He had a black eye that was swollen. The medic notes that the injuries appear to be hours old, okay? His ears were clear, his right pupil was reactive, breath sounds were good, C-spine was good, clavicles were intact, belly was soft, long bones were intact, he was moving his extremities, and they were able to get a saline lock in place. So he kept his eyes closed, and he would only talk to him when he had very, very loud stimuli, okay? So definitely not tracking with him. So there's his vitals. So this comes from Park County, so the drive time, so 56 minutes was an amazing, 56 minutes was an amazing time for them. So his initial vitals were 142 over 92, 20, 98 on room air. Glasgow was only 13. And then right before they get to us, a little bit better on the pressure. Sats are still good, and he's starting to come around a little bit now, so he's kind of going back and forth on this alertness, right? So we do call a level 2. His wife shows up here in the ED. She tells us that a repairman had called her at 12:30. Okay, you see what time we get her. So a repairman had called her at 12:30, said that he couldn't get into their house for a scheduled appointment. She said, oh, he's probably in there. So when the repairman goes in, he finds him down. Okay, this is at 12:30, but the medics found him wandering at 13, whatever, 15. Thought he was a drunk driver, didn't they, or something? Which was on the other side of town. Yeah. Stop. Yeah. So 12:30, when the repairman talks to the wife, it's now 5 o'clock in the evening and we're in the ED, and all of this has happened. So diagnosis from the ED, he has an acute subdural hematoma. He has a subarachnoid hemorrhage. He has a history of vascular dementia, but I don't know how progressed that was. I haven't seen this guy in years. He has essential hypertension. He's got high cholesterol. So we put him in ICU under the hospitalist. So he's got something going on. Remember, the medic described old-looking injuries, older than the acute right there when he was there. So the hospitalist notes that the wife last saw him at about 9:30 in the morning, okay? He was found by the repair guy around 12:30, and we don't get him till 4. So, I have no idea when or what was going on there. The wife felt he was probably walking downstairs and fell, okay? So patient notes say that he's currently awake, he's opening his eyes. This is when the hospitalist is in the room. He was moving his extremities. He did complain of a headache. He was on the nursing unit on the floor. He's actually in ICU. Trauma says he has extraocular movements that are intact. Neuro says he's got a fracture, medial and lateral orbit, non-displaced linear fracture of the zygomatic arch. So he's got some facial trauma, right? And we know he's got some bleeds. So day 2, he's on room air. ENT comes in, says no problem, we'll see him and follow up in the office, which is very common. There's not a lot you can do with that facial stuff until, if I put it up, it's too loud. If I pull it down, you can't hear me. So if it's not uncommon for ENT to wait because it's so swollen that they can't do anything. Neuro says that there's no useful vision in the left eye for several years, so that's already null and void, and he stays in ICU with frequent neuro checks. Day 3, we do a repeat CT. He's pretty stable. Now we find out he's got some fractured ribs. The hematoma is slightly smaller around his eyes. The doc notes that he's, for the most part, hemodynamically stable at 6 in the morning. Okay. At 7:37, neuro says that he's progressively more somnolent, and now he has left hemiparesis. So his speech is muffled, he's incomprehensible. They say maybe we need to think about a cradiotomy, okay, which he does do, and then he goes back to ICU. Day 4, he has an episode of respiratory distress and he has to be intubated. See how he's going back and forth? Day 5, we try and do a wean. He's able to follow simple commands, but we keep him intubated because he doesn't do real well until about noon when we extubate him. Then that night, he tanks again. Now he has another episode of respiratory distress, and we re-intubate him. Day 6, we go, oh, guess what? Now you got pneumonia, so we start some antibiotics. Day 7, we're going to try a wean again, so we turn the sedation down. He got agitated, so we kept him on a vent. But CT says that his bleed's improving. So he got restless on day 8. He's not following commands. Day 9, he's still on the vent. We tried to do another trial. It didn't happen. Day 10, same. Day 11, we extubate him. He's stable. He's off the vent. He's on oxygen and comfortable. He's following commands for the most part. A little confused at 5:30 in the morning. Now we're at 12:56, and neuro says he's so confused that they can't even evaluate him. Day 12, well, now we're alert again. O2 uncomfortable. Later in the day, short of breath, required a mask for O2. Day 13, now he's got some atelectasis. We put him on BiPAP for respiratory. He's lethargic. We bring palliative care in to talk to him. And at 20:54, a rapid response was called, and we intubate him again. Day 14, he's intubated. We do a bronch to wash out the lungs. We can't get him aroused. 15, we extubate him, comfort care, transferred out of ICU. Day 16, he's restless. And day 17, the wife decides to take him home and put him on hospice where he finally died. So, a huge time span between possibly a fall. I think Polly found somewhere where she found blood in the basement? In the basement. So the theory that he fell down the stairs is probably pretty accurate. But I thought the medic did a really, really good job painting this picture because he told us the blood was dried. The injuries to the face looked like they had been a while. His eye was swollen already. So we knew we were behind the 8 ball when we got him. So opportunities, thoughts, comments?
We actually found blood from the top of his basement steps to the bottom. There was blood along the wall, along 3 of the steps going down to the large triangulated puddle at the bottom where he was laid there for a good amount of time before getting up and driving.
So there was an injury prior to falling down the stairs somewhere.
He did, on his way down the steps, he did take 2 different steps and then laid at the bottom for a good amount of time before he was able to get up and drive himself around.
Rob?
So the maintenance guy did or didn't find him at 12?
Found him in the house, but he was upstairs, if I understand right. He was upstairs and was on the floor somewhere on the main level of the home.
No, he wasn't on the floor, he was upstairs, and the maintenance guy thought that he was just normal.
Oh, okay.
Oh, okay.
He didn't really interact with him, from what I gathered.
So he probably didn't have those wounds yet.
Yes, he did. There was blood downstairs, but there was no blood upstairs at all.
So there's nothing that would have tricked the maintenance guy. What else? Was there anything they could have done better? Anything we could have done better?
So, I mean, I think definitely the medics did a great job. This case to me highlights how important it is to identify all injuries. I think maybe it sounds like in the ER, we did not identify the rib fracture early enough. The key thing about rib fractures is, you know, in the elderly especially, rib fractures have a huge morbidity mortality, especially once you go beyond 3 broken ribs and get, what, 7?
I think so.
Yeah. So let's just forget the head bleed. If you take an elderly patient with 7 rib fractures, the odds are against them. Honestly, they get very sick. They usually die of some kind of infection or pneumonia. Now, these complications, you got the head bleed. So the most recent version of ATLS, the course we have to take, Dr. Lynch, myself, it really emphasizes having a lower threshold to image the elderly and make sure you get identify all their injuries very early. And I think you guys actually do a really good job when you guys bring a patient in. Just remember, one injury begets another. So if you see some distracting injury that's very obvious to you, it's a sign there's probably more that you just don't see on the surface.
This one was a real puzzle. Julie and I spent a lot of time on the phone trying to piece it together. I thought the medic did a phenomenal job with that, but there were still holes. I'm like, okay, this makes no sense. How did he get here? How did he get there? So, yeah. Finally go, oh, okay, now that makes sense. What else? Anything else? Dr. Lynch, anything you can offer? So what is your theory then on the, I mean, his, like they intubate, like I think 7 times this dude was intubated.
I think his lung function was very compromised with the rib fractures. What happens is the natural, when you have broken ribs, the natural immune response is not to take 50 breaths and get atelectasis. It's just a progressive cycle that's very difficult to overcome. That's why we take it very seriously. We admit the patients to the hospital. That's the one time we comfortably give opiates or narcotics. We want them to take good deep breaths, keep their lungs strong, prevent atelectasis. So I actually think in this case of thinking through it, he had a lung infection right with the pneumonia, and I think it was just the combination of that had bleeding.
Everything complicated. So I thought that was a really good run. Tell him kudos, tell Jerry kudos. All right, second one, like I said, I already called him out because Chuck is one of the most creative medics I've ever met. You'll see why here in a minute. So they get called for a 40-year-old male. They're dispatched for a stabbing, okay, which we know that could be anything from, you know, something minor to something major. You never know. So the 911 call came in at 18:53. They were dispatched at 18:56 and routed 18:56, on scene at 59, left scene at 07, and got an ED at 12. So definitely a much closer run than coming from Park County. So 911 call to scene time was 6 minutes. They were on scene 8 minutes, so he didn't waste any time. And so from the call to getting here was 19. So the patient is with fire rescue, and he tells them that he stabbed himself because he missed his kids. He used a steak knife, and he stabbed himself 5 times about 30 minutes before EMS got there. He complained of chest hurting and dyspnea. I imagine he did. He denied drug or alcohol use, but the medics note that there's a strong smell of marijuana. He denies any other injuries. Law enforcement searches him for weapons. His airway is patent. His assessment is pretty negative for the most part, and so they decide to transport. So the 5 stab wounds were in the center of his chest, right about the nipple line, so right in the same spot. There was very minor bleeding, and each one was about 1 centimeter in length. His chest was rising and falling just like we want it to. His lungs were clear but slightly diminished in the right. His belly was soft, pelvis was good, neuro was good. He could talk in full sentences. So Chuck clipped the wires off of a defib pad, and he put it over the wounds. So just like you, when we first read that, we kind of chuckled, but it's brilliant. Think about it, because he has an open chest wound. So what's your answer to that problem? An occlusive dressing, and he was able to use 1 dressing and cover all 5 wounds. So we did make fun of him for about 30 seconds, then we realized, oh God, he's brilliant. So we called a level 1, okay, which meant that the trauma surgeons came as well. They did find a pneumo, so he did get a chest tube. They did a fast exam, which was negative, and we admitted him just to a regular nursing floor. So on day 2, we determined that the patient struck his children, so his wife took the children and left. He originally had told EMS that he did it because he missed them. He does have a significant psych history. He was positive for meth, amphetamines, and pot. Behavioral health comes to the party. He is suicidal. They recommend inpatient psych. He threatened to leave, so he was placed on ED and given Haldol for agitation. He disconnects his chest tube from the drainage system, but he didn't pull the tube out, so he knew it was going to hurt if he yanked the tube. Day 3, family comes. That escalates the behavior. We allow them until it becomes a problem, and then we boot them to the corner. Security had to get involved. They had to be removed from campus. Day 4, we purposely take the chest tube out, and on day 5, he goes to an inpatient psych unit. So, thoughts, comments. I don't know what the cost of a defib pad is versus an occlusive dressing, but I thought it was brilliant. For that, yeah. Could he have done anything better, anything different? The guy was, for the most part, was stable. He got the level 1 based on the mechanism appropriately, okay, absolutely appropriately. So we did call it a level 1, which means you get everybody at the party, including our trauma surgeons. Okay, so Chuck had to take a run. He didn't get his kudos. So if you see him, tell him, good job. All right.
Thanks, Jackie. Next up, Dr. Nasser is going to be here to do some talk about ACS and some cardiac things for us. Thank you, sir. Okay.
Well, thank you, Barry, for inviting me to speak here. Just to introduce myself, my name's Tony Nasser. I'm a cardiologist, and I practice out of not just Union and Regional, but we also have our own office here in Terre Haute, a private office that we have an outpatient cath lab, and of course we do inpatient work in the very frequently with our medics, paramedics, ER personnel around not just the city of Terre Haute, but the whole Wabash Valley, all the contiguous counties, be it Sullivan to the south, Greencastle and Brazil to the east, Clinton to the north, Paris to the west, and even Robinson at Crawford Memorial and Lytton. So just to name a few. So I see a lot of familiar faces out here, so I'll just go ahead and dive right in. Before I start, I want to say that I'm not just a heart doctor, just a coronary cardiologist. All the cardiologists in our group are also vascular specialists, not just venous, but also arterial, non-invasive, invasive for acute limb and critical limb ischemia. But we'll focus the energy today on acute coronary syndrome. So I'll stick to the heart rather than expand upon the arteries. We'll jump right in. So the most common complaint that we get as a cardiologist, very common for you guys in the field and the ED, is chest pain. When you hear the word chest pain, I hear this all the time. Chest pain can be heart, obviously. It can be non-heart. Anytime you hear the word shortness of breath, those two are synonymous. It's classic. 50% of females, and this is Heart Disease Awareness Month, in the month of February, heart disease awareness in females. Half the females present with shortness of breath, but not chest pain. Just because they don't have chest pain doesn't mean they don't have a acute coronary syndrome. Shortness of breath, especially in a female, especially in a diabetic, half of females, 1/3 of males, take that as a pearl, okay, can present with the differential diagnosis. And we mentioned acute coronary syndrome. When I say the word acute coronary syndrome, I'm referring to STEMI, non-STEMI, hot angina with EKG changes. The real deal that we see, the troponin may be negative, but they're having ongoing anginal type chest discomfort, dyspnea, jaw, back, neck discomfort, arm, radiating into their back. And please do not miss pulmonary embolism. We bury a lot of pulmonary emboli that we never diagnose because we miss them. We send them out of the office, out of the hospital, out of the ED. We don't think about it because it's, we think chest pain, shortness of breath. Oh, it's probably a heart or not a heart condition, especially when they look sick. And you have that gestalt when you see them on the scene. Thirdly, aortic dissection. Do not miss that one. You'll kill a patient if you miss that diagnosis, meaning the classic chest discomfort, tearing and quality into the back. That's a classic history, okay? The treatment for that is the opposite of what we do for acute coronary syndromes. For acute coronary syndromes, we're given antiplatelet therapy, anticoagulant therapy, rushing to the cath lab to shoot the coronaries, giving blood thinners to an aortic dissection, giving clopidogrel or ticagrelor, which is Brilinta brand, potentially could kill an aortic dissection. Giving TPA to an aortic dissection will likely exsanguinate them, and you'll take out all the surgical options and endovascular options to help that patient. Pneumothorax, you'll get that classic history, of course, in trauma, penetrating trauma or blunt trauma, flail chest, dyspnea, trachea that's deviated. They're blue, they're unstable, tachycardic, tachypnic, hypotensive. Spontaneous pneumothorax can occur. It doesn't have to be a skinny morphinoid looking patient. It can occur in a normal body size and body habitus patient. So never miss these 4 in the differential diagnosis of dyspnea and chest pain. ACS, PE, air dissection, pneumothorax. This is a classic visual verbal explanation of the Netter diagram, for those of you that can see it, of a patient clutching his chest, the classic Levine sign. Anytime you come up to a patient and they say, I'm having chest discomfort or chest pain, and they do this, a clutched fist over the chest. That's called Levine sign, named after Samuel Levine, a famous cardiologist from Boston in the 1930s. That's a classic description of angina, okay? Anginal type chest discomfort. A lot of patients, if you ask them, are you having chest pain? No. On to the next question. Are you having this, that, or the other? And you go through the review of systems and the history. And then they'll come back and you look at the EKG and they're having a heart attack and you'll say, well, aren't you having chest pain? No, doc, or medic or paramedic, I'm not having chest pain. I'm having chest discomfort, chest tightness. Well, that's what I ask you. Are you having chest pain? No, I'm not having pain. Pain to them might be their perception is stabbing, excruciating. It's more of a sensation, a discomfort. So ask the questions correctly. Are you having chest discomfort, chest pressure, chest heaviness? A lot of patients don't consider that pain, okay? You and I do. And just because they're not having chest pain doesn't mean they're not having this differential diagnosis of ACS, PE, air dissection, pneumothorax. All the other things that it could be are probably not killers. GERD, esophageal spasm, psychosomatic, costochondritis, gallbladder, unless it's ruptured gallbladder with, and usually that's acute abdomen that they're presenting with. But, and pancreatitis, a lot of these other things don't cause death. Now, this is apropos, okay, and I put this in special. He used to be a hot reactor before he got his amiodarone-induced blue nose. I think if you all saw it on ESPN on Saturday afternoon, poor Bobby Knight. He's a hot reactor, okay? So when we talk about hot plaques, ruptured plaques, these are the patients that smoke's coming off them, okay? They look gray, blue around the gills. You see them, they're tachycardic, hypotensive. They have marked EKG changes, whether it's ST segment depression, ST segment elevation. Okay, that's what we're talking about, hot plaques, okay? We're not talking about office patients that are seeing us for a differential diagnosis in the office. We're talking about the emergencies. Let's do it with a case. Let's start out with a case. Let's talk about this patient. This is a 52-year-old white female, history of tobacco and methamphetamine abuse. The patient you'll ask a lot of patients, when did you last use meth? Oh, a long time ago. And a long time to them is like a week ago, okay? I quit a long time ago. And this patient reportedly said 6 months ago. And complained of substernal chest discomfort, pressure, heaviness, probably with a classic Levine sign, clutched fist over the chest, presenting to the emergency department at Union Hospital, waiting room. So checking in, and the triage personnel look at the patient, and all of a sudden, right before they're ready to roll the patient back, the eyes roll in the back of their head, and quote unquote, the patient's having a seizure. Follow me? Well, the patient has a brain anoxia or cerebral anoxia because there's no cardiac output from this rhythm. Guys, what's that rhythm right there, everybody? VFib, yeah, that's VFib. And the rhythm was VFib. Patient was defibrillated successfully, sinus return of spontaneous circulation restored, and the patient's got a systolic pressure of 90, heart rate of 120. Problems. Here's an electrocardiogram. The first thing on electrocardiogram, the first thing to do is not look at this, that, or the other. Look at the name and look at the date. Trust me, as I'm standing here right in front of you, you will make this mistake, as I do constantly. I look at the wrong data, the wrong patient, the wrong date. Last year, it'll say today's the February 11th. Yesterday, I looked at a patient, February 10th. I was reading an EKG, 2019. I said, oh my God, they're having a heart attack. No, that was last year. It just happened to be 211, 210, okay? Look at the name, look at the date. Remember this, that's the first thing you do. The second thing you do on EKG, find the P wave. So important. The best lead to find the P wave is usually limb lead 2. PQRST, so you know you're in a sinus rhythm, and this patient, you know that the heart rate is 300, 150. It's just a little bit above 100, about 110, 120 on this heart rate. So a little sinus tachycardia, and go ahead and this patient's having anginal type chest, or I'm sorry, just had a quote unquote seizure with return of spontaneous circulation after a VFib defibrillation. Anybody in the audience, tell me what you're seeing on the EKG. Anybody? Elevation. What leads you to see in the elevation in ST segment elevation? That's right. That's right. 1 and AVL. These are the high lateral leads, 1 and AVL. And you're seeing, you're right, V2 through V6 actually, 1 and L. So that's anterior lateral. And you also, classic, you see in reciprocal changes. The opposite or inferior ST segment depression, okay? So this is an acute anterior lateral STEMI, okay? And unfortunately, I'm gonna go out of order a little bit. This patient didn't make it, okay? And this is what the pathologist showed us. And you can learn a lot from that angry Bobby Knight plaque that we talked about. Notice right here with the lipid core labeled here, this is the lumen of the artery, and this is thrombus right here. I challenge you, that dark area, it's not just red thrombus from thrombin, it's also white thrombus, platelet mediated, okay? So I'll come back to that in just a moment. You can see the other features of this plaque. You can see the vulnerable shoulders or the vulnerable plaque that ruptured here, and it's an irregular border in these smaller. So this is the pathophysiologic criteria for an unstable ruptured plaque that causes an acute coronary syndrome. And I challenge you, prior to this thrombus right here, from the ruptured plaque, this lipid core, this lesion was 40–50%. The majority of heart attacks don't occur in 80–90% blockages. The majority of heart attacks, more than 75%, occur from lesions 50% or less, meaning there's no time for collaterals to form. And that's why you get an acute ischemic event like VT, VF, hypotension, cardiogenic shock. That's why there's no chance to accommodate the heart muscle, okay? It happens abruptly or acutely, okay? Hence the Bobby Knight angry plaque look, okay? Now, back to the thrombus. It's not just red clot. Of course, we give either heparin or low molecular heparin like Lovenox brand, enoxaparin. A lot of patients consider, of course, we consider that blood thinner. A lot of patients consider, oh, aspirin's a blood thinner. That's true. Aspirin's a different blood thinner. It's an antiplatelet. It treats the white clot, platelet-mediated thrombosis. And we commonly give, if we're in the cath lab, trying now not to give it in the field, P2Y12 inhibitors, which are the ones we use in the Terre Haute area are clopidogrel, which is Plavix, or ticagrelor, which is Brilinta. Ideally, long story short, without getting a lot of debate, we like to wait till they're on the cath table and decide if we're going to put a stent in or not before we give a P2Y12 inhibitor. So we treat the white clot with aspirin and P2Y12 inhibitors, be it Plavix or Brilinta, and we treat the red clot with either heparin, enoxaparin, or bivalirudin. Okay, and that's more of a cath lab drug. So, what's the diagnosis in this patient? I think we all said it's an anterior STEMI. Should we give amiodarone? Show of hands that we anticipating you're going to get orders for on amiodarone, unless you have a protocol for VF arrest. What's your protocol say in the rigs? Amio. Yeah. What dose are you given?
300.
Excellent. I concur. Okay. 10 minutes is reasonable. If it's stable VT, I'd say within 3 minutes. So 3 to 10 minutes on the 150 bolus. Start them at 1 milligram per kilo per hour for 6 hours, then cut it down to 0.5 milligrams per kilo for the next.
Study that said if it was not within that 8 to 12 range, then it was like 50% less effective. Was why I say 10 minutes.
Little controversial. You can get hypotension if they have stable ventricular tachycardia that you just cardioverted with amio bolus. There's a beta blocker effect in amiodarone. Amiodarone is a complicated drug. It's got calcium channel antagonist properties, sodium channel antagonist properties. Beta blocker. It can cause hypotension. That's why the 10 minutes. Some say 3, some say 5, some say 10, but it's a little controversial. Usually it's urgent when you're given amio, but bolus at 300 if it's a VF arrest and you're unstable. Okay. Labs. What labs do you anticipate the ER is going to want, guys? What's a rainbow?
Just for all, usually PCCs, we give two greens.
No, but think, what are you drawing? What do you want to know about? You want to know about the hemoglobin? You want to know about the platelets? You want, yeah, it's probably the troponin. Hopefully you caught it early. It's 0. You want the troponin to be 0. You don't want the troponin to be positive. Troponin will take 3 to 6 hours. What else you want to know? You want to know the renal function, because you dose your drugs based on renal function, especially these antiplatelet agents. And you know the risk of acute kidney injury if you're going to the cath lab and you're giving contrast, or you're doing a CTA for a pulmonary embolism or aortic dissection with contrast. You want to know what that renal function is. Electrolyte disorder. You treat something reversible. If they're hyperkalemia and you see a ST segment elevation, you're not going to the cath lab. You're going to treat the patient, the hyperkalemia. They're acute kidney injury, acute hyperkalemia. That's what we call a dialyzable current of injury. So you want to know what the potassium is. So you say rainbow, and I'm not arguing with you. I want you to think, get in our minds, what's the medical team doing? What's everybody's goal? Help that patient. Why are we drawing a rainbow? To do all those things we just mentioned. Good. Dual antiplatelet therapy, DAPT, okay? I would say hold off on giving P2Y12 inhibitors in the field and in the ED unless we know this patient's not going to surgery. It'll cause bleeding if the patient ends up in surgery. There's probably a 1 to 5% chance acute coronary syndrome patient's going to go to surgery. Depends what population you're looking at. You're looking in the Midwest, you're looking at around the world, what ethnic group you're looking at, what gender group you're looking at, elderly or young, 1 to 5%. And there's a small chance, and you don't want to burn that option. And we have some IV agents that we can use that load without giving an oral agent. An echocardiogram, if you have time, it sure helps with pericardial fusion for hypotension. If you have an equivocal EKG, we'll get an echo frequently in the ED. Do you guys have capabilities to do ultrasound? Sometimes the ER has those quick looks for trauma. We can look at see if there's a pericardial effusion, but an echocardiogram, if it's timely, it doesn't delay the transferring that patient, the care of that patient can really help with diagnosis. If the patient's hypotensive, I think this patient, you say, oh, the pressure's 90, it's fine. Yes, pressure's 90, but the heart rate's 120. That's early cardiogenic shock. I want you guys to pick up on the subtle findings of early cardiogenic shock. Oh, systolic pressure's fine. Yeah, the heart rate's 120 though. The patient's manifesting a tachycardia to maintain the cardiac output. Okay. Cooling protocol, controversial. I'll leave this off. That's more up in the ICU. And emergency cath. I think we want to hightail it to the cath lab. Guys, now we're judged on, it's no longer door to balloon. Come in the ED, open the artery. That's our criteria we meet to be a good hospital, a good medical team as a acute MI center for accreditation. No longer. The rules have changed. It is now first medical contact to open artery. The clock starts when the first medical person, usually the ambulance, arrives, or medic, paramedic, EMT. That's when the clock starts. Show of hands, who's comfortable sending an EKG from the rig to the ED? Show of hands. Okay. Can only see about 20% of y'all. Okay. What's the capability? I heard earlier from Barry Nicholson that 87% of the rigs are able to transmit.
No, well, most of them can transmit. I said we are 87% accurate at this point in time.
Okay, when you say most, Barry, just to repeat for those that couldn't hear Barry, he said 80% of the diagnoses made by the medics, paramedics in the field were accurate on their EKG diagnosis in an internal review for the Wabash Valley. What percent of your rigs have ability to transmit an EKG pre-hospital arrival? 3 rigs out of how many? 3 out of 15. What's it take to go to 15 out of 15? 4 out of how many? What's the denominator?
Ileana can transmit 2, and they got 3, so 6 out of 6 total. That's it.
6 total out of what's the denominator?
I'd say around 24, 25.
Okay, so it's something in your mind. 6 out of 20 to 24. What does it take to get to 100%? So I think that's the standard of care, okay, for improving outcomes. What's it take? And that's a debate later, or a discussion later, but it sure would help. The cases I've been involved in, we have pre-hospital transmission, really helps the time for first medical contact to organizing all the players involved, not just the ED. The cath lab personnel have to come in from home. They don't live in the hospital. It's intrusive. It'll burn out the staff if everybody's living in the hospital waiting on the STEMI. Gosh, last week we had 10 in 5 days. The week before we had 0 in 14 days. Okay, and it's hit or miss. It's rain or sunshine. Okay, so communication is going to be the way we improve our outcomes, whether we do it internet, EKG transmit, using technology. So back to our case. This patient went for emergency cardiac catheterization for acute anterior STEMI early cardiogenic shock. And as you can see, show of hands, how many people in this room have seen a heart catheterization? Show of hands. Okay. about half, okay? This is what the catheter looks like coming up from the groin. We can also go radial. There's the left main. Here's the left circumflex, first obtuse marginal. There's the LAD, the left anterior descending coronary artery, where that large red arrow is. That's 100% thrombotic occlusion, TIMI grade 0 flow to the left anterior descending coronary artery. And you can see the next slide over. There's the guide, 6 French guide with a wire. It's a 1400ths of an inch guide wire that goes down, and a balloon is placed. And that's the balloon and the stent. And by the way, we did a aspiration thrombectomy for this 100% thrombus. And we also gave concomitant antiplatelet therapy. Typically, we'll use eptifibatide, which is integralin, what we call a 2B3A receptor inhibitor. It's basically an IV version of Plavix or Brilinta. And that allows the Brilinta to kick in usually within 1 to 2 hours for Brilinta, clopidogrel or Plavix, 3 to 6 hours, depending on a lot of cofactors and comorbidities. And then you can see the ultimate angiogram. TIMI grade 3 flow, widely patent stent. That diagonal did not get pinched. We got that diagonal flow down the diagonal here, here. And you see all the muscle in jeopardy, this whole anterior wall. And this patient made it. And here's what the aspiration, I skipped that part. Aspiration thrombectomy for the thrombus burden. This is what the catheter looks like. And this is what we sucked out, a large amount of thrombus. Now, once again, I want to reemphasize. It looks red. You think makes sense, give heparin or Lovenox, but also treat the platelets. Dual antiplatelet therapy, aspirin, Plavix, or aspirin, Brilinta, okay? And concomitantly, we'll use IV eptifibatide or tirofiban, which is Aggrastat brand or in the cath lab, okay? And I put Mr. Clean, so we're trying to clean out the arteries, okay? This is what a stent looks like. This is what it looks like undeployed and deployed. Whether we use drug-eluting stent or better metal stent for ACS, that was an old controversy back 5 years ago. Now the controversy has been settled. Drug-eluting stent is the way to go. Okay, that's the short version. And while I'm on that stent topic, Jake, can you pull out that iPhone piece right here? And you can. I brought some stents in. We'll pass around, and then you can pass those around. Start some of the back. Tiny ones, 2 to 3 to up to 4 millimeters for coronaries. So these are coronary stents that are going around, and here's a kind of a cartoon of a big one here. This is one of the larger stents. This is one we use for the aorta right here. Lots of, not very flexible, but very big. Then, okay. Now, cardiogenic shock, big topic, guys. We got some newer treatments that are available. Newer doesn't always mean better. There's controversies right now whether to use a balloon pump, Impella, CPS, made by Abiomed Corporation. We want to catch them early in cardiogenic shock. Time is muscle. So I get it. In the field, you want to get the history, appropriate history, physical. That's a first assessment. Like a trauma, you do your first assessment, you do your second assessment, and then definitive treatments, okay? We need that patient in the hospital on the cath lab table. Ideally, not stopping in the ED, going straight to the cath lab. When the cath lab team's available, meaning they have the appropriate personnel to manage that patient's airway, administer medications with a registered nurse and a technologist that can run the equipment, and obviously the interventional cardiologist can do the angiogram and the percutaneous coronary intervention. But to recognize early cardiogenic shock, tachycardia, even with the normal blood pressure. Shock does not mean hypotension. Shock means metabolic acidosis and or not delivering appropriate oxygen at the cellular level. And when you catch them early, you'll get good survival. You catch them late, you delay, do a CT scan. Let's do a more detailed history and physical in the field, delay. Let's get in traffic. Let's not transmit the EKG. Let's not get the people organized. That's when we get bad outcomes, okay? Time is muscle. That's the other concept I want you to take away. And you got to multitask as we go, okay? Very important to get that patient efficiently. I didn't say fast. I said efficiently, which means safe. And you got to use a lot of judgment. And you guys know what time management skills are like in the field. You guys know it more than just as much as anybody as part of this team. So that's the first case. Any questions about the first case while we're sitting here? Okay. Okay. Everybody able to pass those stents around? Okay. Keep passing those around. And then Jake, if you could show them pass a balloon around, that balloon catheter and that wire in the hoop. Start one in the back, one in the front. And the wire is 1/1400ths of an inch. You can sit there and play with it, see how fine it is and how it could easily be bent. And that catheter, that's a balloon dilatation catheter, that'll pass that around while we're sitting talking about the next case. This next patient, 64-year-old white female with coronary disease, status post coronary arterial bypass grafting ×3 in 2014, complaining of substernal chest discomfort for 3 hours prior to arrival to the ED. The patient's lost to cardiology follow-up, non-compliant, not taking meds, still smoking. Who knows what they're smoking? When they say smoking, that could mean nicotine, it can mean cannabis, it could be meth. You can pass that one around too, Jake. And those wires too. It's so common. People look at the cannabis, right over, as the crow flies, 5 miles away from us. It's quote unquote legal. It's herbal. It's normal to smoke marijuana. I'm here to tell you guys, I'm gonna say this firmly. Cannabis use and abuse is a cardiovascular risk factor. We're gonna rue the day that we legalized it, okay? From a public health standpoint, I'll argue with anybody on the scientific facts because I have experience in this area, living here for all my life. I see a lot of problems. I have not yet seen a 50-year-old heart attack patient or under that wasn't abusing nicotine, cannabis, meth, or all three. Not yet. Every young one is abusing a substance that potentially is a modifiable risk factor. I've never seen a 50-year-old or less that that didn't smoke something, okay? Not zero. Now, I'm gonna challenge you guys again. What's the first thing you do on an EKG, guys? Everybody, name and date. Check that name and date. Make sure you got the right name, right date, and tell me you find that P wave, okay? Find that P wave. P, long, prolonged R interval, PR interval, QRST. P, prolonged PR interval, QRST wave. So anybody want to take a stab at this one and read this EKG? Substernal chest discomfort, coronary disease, previous cabbage. Anybody? What are you seeing? Acute inferior ST segment elevation. First degree AV block, good. Sinus rhythm, sinus Brady, first degree AV block, acute inferior ST segment elevation consistent with a STEMI. And where are the reciprocal changes? What leads you to see reciprocal changes in? That's right. High lateral, 1, AVL, V1, and V2. So you suspect it's what artery would that correlate to? More times than not. More times than not. Can be at OM, but yeah, right coronary artery. But this patient had bypass, so it changes the physiology a bit. Once again, here's this patient didn't make it either, unfortunately. I'm 0 for 2 now. Here's what that ruptured plaque looked like. It's a thin cap fibroatheroma. And once again, I want to reemphasize. To the average person that's not in the pathology field, the pathophysiologic field, heart attacks occur in lesions that are 80, 90, 100%. That's not true. Majority, 3/4 of the heart attacks occur in lesions 50% or less. This is a thin cap fibroatheroma. It ruptured abruptly, no chance for collaterals, and that's what a ruptured plaque looks like. And you guys got the diagnosis, inferior STEMI, labs. We're going to do the rainbow. Okay, we're going to know the hemoglobin platelet count, because that changes things. If they're the thrombocytopenic, they're anemic. If their electrolytes are off, their acidosis, their acute kidney injury, their sugars up high, up low, down too low. Okay, it changes things. Troponin, we got a diagnosis. The troponin, I hope it's 0 because you hopefully got to them early. Just give aspirin, okay? If you can't give it orally, where else can you give it, guys? For vomiting. Yeah, you can also give it rectally. Not fun. I won't go there, but And if they really can't swallow, you can give it under the tongue, a soluble aspirin. If they're intubated and you have an OG in, you can give it down the OG, crush it and give it an OG. As I mentioned, the other route, we won't talk about that. Echo, as long as it doesn't waste time, it really gives a lot of advantage, especially if they have acute kidney injury or a chronic kidney disease. An echo can help prevent us from doing a left ventriculogram, where we spend another 20, 30, up to 40 cc's of contrast. Pressors, if they're in shock and we're not in the cath lab, we don't have access to a balloon pump yet. Fluids for an inferior. Ideally, try not to give nitro immediately, reaction, okay? For 2 reasons. Number 1, inferior MI. The RV needs preload. And you can think about this after our lecture, but when the RV expands, you want to give volume, okay? Because if you give an afterload reducer like nitroglycerin IV or nitroprusside, you can cause hypotension because you're vasodilating too much. Secondly, I make this mistake all the time. You'd be shocked how many patients, males and females, use PDE5 inhibitors. Viagra, Cialis, Levitra, which would be varsenafil, tadalafil, and sildenafil. Ask them if they're used before you give nitro. We commonly, chest pain, oh, give a nitro. Okay, no problem, as long as the pressure is above 100. And yeah, you want to make sure they're not hypotensive before you give it. Ask them about those, because you'd be shocked how many people are taking this stuff. It's over the counter. You can get it on the Canada for free. You can internet, and you don't need a prescription for it anymore. They sell it on the street all the time. Women take it. Yeah, I'm telling you, women take this drug. Shocking. I had one yesterday, got hypotensive in the cath lab. I gave him nitro through his radial artery catheter. Why is his pressure 90? Oh, and then dropped to 80, and then 70. I forgot to ask him, did you take a Viagra? Oh, yeah, I took it this morning right before my cath. Oh my God. So there you go. You got to ask, guys. Be careful out there. It's a dangerous world out there.
Questions from the audience, but that's okay.
Barry, don't admit to anything, Barry. Yeah. Plead the fifth. Don't assume anything. You got to be careful, guys. It's a dangerous world out there. We do so many things reflexively. Give IV fluids, and then you go, oh, I'm gonna drown them. Or give nitro. Whoops. Did they take Viagra, Cialis, or Levitra? Whoops. Is it inferior RVMI? Can I make things worse by giving nitro? You got to think. So that's why I want you to get in. This is a mode right now. We're in a chalk talk mode. This is the time to interrupt me and ask questions. Please, it's that way. It's interactive. The cooling protocol, I think that's kind of been poo-pooed lately, unless there's total cardiac arrest. And we're going to the cath lab with this patient. If there's no contraindications, they're good protoplasm. And for those, once again, that haven't seen a heart cath before, this is the catheter. These are the sternal wires from the previous cabbage that was done in 2014. This is the graft that goes to the right coronary artery. Saphen's vein graft, distal right coronary artery, 100% blocked at the mid shaft where the red arrow is. And you can see, let's see, we do a wire, and everybody got a chance to touch that 1,407-inch wire out there, and we snake the balloon over the wire, and here's the balloon between those markers. If you look real closely on that balloon that Jake passed around to you, there's a little radiopaque marker here and here. The working part's in the middle, surrounded in the oval circle, red circle there. And that's where the thrombotic ruptured plaque was, and the thrombus burden. We sucked back with thrombectomy, and we put a stent from here to here. Everybody got a chance to touch those metal stents? Okay. So Jake, when you get a chance, get your iPhone box and collect those stents here. So you got a nice patent artery, TIMI 0 flow, TIMI 3 flow. Now you can see that distal RCA that is lighting up, that was causing the acute inferior ST segment elevation myocardial infarction. And that was a successful STEMI. Unfortunately, the patient didn't make it. We had a bradycardic death. Pacemaker didn't capture, and went to the pathologist. Once again, the stent, balloon over the wire, fully deployed stent. Okay. Now, questions about that case. So I showed you anterior STEMI. I showed you inferior STEMI. I showed you one that was native coronary arteries. I showed you one with bypass arteries, okay? Now let's talk about another patient, acute coronary syndrome. Case number 3, 60-year-old white male with multiple cardiovascular risk factors. What are the risk factors? Tobacco abuse. Somebody else. Hypertension. Yeah, obesity. That's funny you say obesity. Can I save that one for the last? Let me save obesity for last. So smoking number one modifiable risk factor. If you quit smoking, you lower your chances for dying from a heart attack by 50% over the next 5 years. That's pretty impressive. Not to mention cancer, stroke, TIA, major adverse limb events, peripheral arterial disease, toe amputation, foot amputation, AKA, BKA, okay? Oh, and by the way, bronchitis, pneumonia, okay? Morbid, not just mortality, okay? So smoking. We mentioned hypertension. Very important to modify the hypertension. Beta blockers are the key for acute coronary syndromes and stable heart disease to control angina and hypertension. Also ACE inhibitors or ARBs. When I say ACE inhibitors, ARBs we use interchangeably. What else? Diabetes, yeah. Control the sugars. Diabetics. Diabetic female, 8 times increase the risk over a non-diabetic male, okay? Females want to be equal to men's. We got this, you know, back when I was a kid, when I came to America, they had this thing called women's lib, okay? Women want to be cool. They had this thing called Virginia Slims tournament. Yeah, play tennis in the 70s with Billie Jean King. Yeah, we're going to smoke. We're going to be just like the men and smoke. Unfortunately, that was a bad public health statement. It was chic to be smoking and wearing pants, not a skirt, not a dress. And unfortunately, tobacco abuse and led to increase in cancer and heart attacks. But what's the number one killer of females in the United States of America? Heart disease. If you take heart attack and stroke, that's the same risk factors that we're mentioning, that's 50% of all Americans, men, women. Look to your left, look to your right. One of those persons is going to die of either a heart attack or stroke. Okay? You take all the other diagnoses we have. Barry, just plead the fifth, Barry. If you take all the other diagnoses, AIDS, breast cancer, prostate cancer, suicide, COPD, take them all, whatever diagnosis, SARS, what do you call it, coronavirus, okay? Take them all, add them all up, multiple sclerosis, okay? Add everything up, heart attack and stroke still number one, okay? Now, we've done such a good job in heart and stroke for cardiovascular awareness, risk factor modifications, that now, this year, 2019, we just finished, cancer overtook heart disease as number one in men and women both. So is it because we're doing a great job, or are we getting more cancers right now? So you got to be careful with data. You can massage data any way you want. It's still a really common condition, heart attack and stroke. Now, we mentioned tobacco abuse. We mentioned hypertension. We mentioned diabetes. Another risk factor, we'll come back to obesity. We said diabetes, okay? Those are the big four. We can't change the genetics. People working on it. It's not ready for prime time right now, okay? We won't go there either, changing genetics and genders and all that. We'll skip that part. But now let's go back to obesity. Is obesity a risk factor? The short version, scientific answer is no. The reason obesity is not a risk factor for heart disease, if you do multivariate analysis and you just look at the univariate model, obesity is not a risk factor. But what leads to obesity? Imagine, visualize what an obese person looks like. Sitting on a couch, smoking, watching TV, eating carbohydrates. What does all that do? Smoking, carbohydrates leads to diabetes, raises their cholesterol when they're eating fat. They're not active, they're sedentary. Those behaviors lead to risk, but it's not the obesity itself. It actually is a paradoxical way of looking at it. So, okay. So now let's go back to this EKG. First thing you do, name, date, find the P wave, sinus rhythm. Anybody want to take a stab at this EKG? What are they seeing? Not possible. No, you're confident. You're confident, guys. You're in the field. You're making the call. These are the things, didactics, you need to really brush up on. You don't need to be possible. Consider. The reason you know it is because you see greater than 1 millimeter ST segment elevation in 2 or more contiguous leads. That's 2, 3, and F. With reciprocal changes in V1 and V2. You're confident this is acute inferior STEMI, and you're rocking to the local ED that has PCI capability in an ideal world. And this is, you guys have done enough caths now. This is your third one now. And here's the right coronary artery, 100% thrombus, and it's nasty right off. You'll put another stent in. All things are good. Now this patient develops a problem, bradycardia, okay? And you can see second degree AV block, Mobitz type 2. Okay, we'll save that for another lecture. So second degree AV block type 2. Okay, you win the battle, but you lose the war. The patient dies. Well, how do you prevent him from dying? You need to put an emergency pacemaker, either a temporary wire in or a permanent pacemaker. Jake, pass this around. Jake's got a box. This is actually an ICD that has all ICDs have pacemaker capabilities. Pacemakers do not defibrillate. ICDs do, but all ICDs have pacing capabilities. And it goes typically under the left subclavian. In the old days, we had larger boxes that had to go in the abdomen. And that's what a pacemaker looks like. And here's the indications that I'll list here. This is not really a lecture on bradycardia, but these are the indications for pacemaker. You, of course, know the external, temporary wire, permanent pacemaker. And we had successful PCI to this distal RCA. And you can see the pacemaker that went in temporarily. Okay. And Barry, how are we doing on time?
You're good, whatever you want.
Okay, let's do one more case, then we'll summarize, okay? Now, we started this morning, about 45 minutes ago. We started with the differential diagnosis. Quote unquote chest pain, okay? Let's review. What's the differential diagnosis for chest pain? And when I say chest pain, shortness of breath. Pulmonary embolism, yes. Pneumothorax, okay, keep going. Acute coronary syndrome. Yeah. Okay, and you can really screen them. You got to think about all four, the big four. Do not miss the big four, guys. You miss the big four, you're going to kill somebody. Okay, they're going to do poorly. You have to think about aortic dissection, pulmonary embolism, and pneumothorax because they're not intuitive. Heart, it's easy. Okay, STEMI, non-STEMI, angina, but we always forget PE, pneumothorax, and aortic dissection. Do not miss them. Okay, now this is let's see if we can figure it out as we go. 61-year-old white male complaining of chest discomfort and dyspnea, arrives at the ER at Union. Recent 5-hour bus ride from Indy to Chicago, had a previous splenectomy. Okay, EKG, the right name and date, and you look and you got a sinus tachycardia. Okay, blood pressure 60, heart rate's 120. I'm sorry, I meant sinus tachycardia. I meant AFib with RVR. I apologize. I'm so sorry. AFib with RVR. You got bilateral jugular distension. Lungs are clear. No crackles. No edema in the legs. D-dimers 10. Troponins in the normal range. The BNP is normal. And okay. Okay, I'm hearing PE is the number one. What's in your differential besides the PE? What else could it be? You said PE is number one. Good. Could be ACS. Could be a aortic dissection. Yeah, could be a pneumothorax. Could be. But I said the lungs are clear, and here's, it's not pneumothorax. Here's the lung tissue. And you guys went right to the PE, and that's correct. Got a saddle embolus. Hypotension, okay? That's the left pulmonary artery, and you see right pulmonary artery, bilateral, big time, hypotension with PE. So, and by the way, the venous Doppler, this is the next day. This wasn't emergently, you didn't need this in the ED, but was a left popliteal peritoneal DVT, but that's in the knee and below the knee. They're probably not there anymore. It was in the femoral vein, in the common femoral vein. A large cigar went up to the lungs and caused that acute pulmonary embolism, enough to cause hypotension. So the plan is not to go to the cath lab. I get this all the time. Hey, Master, you do vascular. You want to take this patient for the catheter-based pharmacodynamic therapy. The brand name is called ECOS. We just call it the ECOS. Okay, the ECOS. That's not a class 1 indication. This is as long as the patient doesn't have a bleeding issue, meaning a recent intracranial hemorrhage, systolic blood pressure greater than 180, thrombocytopenia, acute anemia, acute GI bleed, recent stroke within 6 months, ever had a hemorrhagic stroke. As long as you don't have a contraindication, recombinant tissue plasminogen activase, or TPA, is the key. Versus pharmacomechanical therapy, that's the ECOS. Surgical thrombectomy, that's morbid as heck. You got to start pressure to support the patient, got to give oxygen, maybe have to intubate. We give concomitant unfractionated heparin or low molecular heparin after the thrombolysis is done. Later, we go to oral anticoagulation, be it vitamin K antagonist or non-vitamin K oral anticoagulant. Concomitant aspirin is controversial. Beta blockers to control hypertension if that occurs, but the contraindicated now with hypotension to control the AFib. If the patient's had two pulmonary emboli, we look for a thrombophilia or a hypocoagulable state, and always look for the cancer. Cancer can cause what do you call thrombophilia. This patient had a recent trip, 5-hour bus trip, likely the provoked DVT that led to the venous thromboembolism, large PE. Okay. This patient got TPA. Okay. All right. That's another topic. Talk about that later. So I'll summarize our last slide, guys. ACS for our discussion for our group. We'd like, ideally in the United States of America, dual antiplatelet therapy for 1 year, aspirin or Plavix or Berlina, or there is Effient. We don't use that much in the Wabash Valley anymore. You're predominantly using these two. We say 1 year in the United States. In Europe, 6 months. New data came out last month, 1 to 3 months, okay, for new stents. It's not yet in the guidelines for the American College of Cardiology, the American Heart Association, or the Society of Cardiac Angiology and Intervention. So the American guidelines is still 1 year today. That's by the book. If you have a circumstance, hey, the patient's got to have emergency surgery, you're going to have to stop it early. If you have a patient that's got ulcers, it's reasonable to stop it at 6 months. If they got bruising, bleeding, but that's under the guidance of the cardiologist on an outpatient basis. High dose statin, regardless of your cholesterol. Once you've had a major adverse cardiovascular event, stroke, heart attack, bypass, stent, every patient should be on a high dose statin if they can tolerate it. Only 90% of people can tolerate statins. Probably only 80% of people can tolerate high dose statins. If one statin doesn't work, you can try a different one. There's lots of statins out there. There's non-statin therapies that are now available called PCSK9 inhibitors. They're really popular. They're monoclonal antibodies. They're very expensive, but they have great outcome data. And there's multiple trials in large, well-randomized controlled trials. Now there's a new fish oil, not the fish oil you and I are used to at GNC. There's new fish oil, a real fish oil called Vascepa. It's got a brand new indication for lowering death due to cardiovascular disease, major adverse cardiovascular events like stroke, heart attack, and recurrent repeat intervention, be it percutaneous or surgical. Vascepa brand, icosapentatic acid. Lastly, there's ezetimibe or Zetia brand, expanded indications, reasonable to add on to statin therapy. Beta blockers, great as long as they're tolerated. If they're indicated, don't give them to somebody with bradycardia and hypotension. When I say ACE, ARB, these renin-angiotensin blockers do something more than just lower blood pressure. So regardless of LDL, HDL, idostatins are good. Regardless of blood pressure, beta blockers and ACE inhibitors, they do something positive to the patient. It's more complicated. It's a little beyond the discussion that we'll have right now. Wearable cardiac defibrillators, a little controversial, the Life Vest. It's a class 1 indication to have the conversation with the patient or family. Would you like to have this before you leave after you had a cardiac arrest with a heart failure, reduced ejection fraction? It's reasonable to have the conversation. It's not a class 1 to discharge, and you must go on a life vest before you leave the hospital. That's not true. It's what we call 2B by the guidelines. In brief, it's an insurance policy. It's individual basis. Not everybody has to have it. Cardiac rehab is a class 1 indication. Before every patient that has a heart attack, stent, bypass surgery, it's appropriate to refer them to cardiac rehab. Whether they can do it or not, that depends on their physical musculoskeletal abilities. And same thing for stroke. Stroke rehab is important for every patient as long as they can do the physical therapy and occupational therapy. And once again, we talked about cardiovascular risk factor modifications. I put this last, not because it's the least important, because I put it last because cardiovascular risk factor modifications summarizes what we discussed to prevent before they come to the emergency room, before our medics and paramedics see them in the field for the big 4, tobacco, hypertension, diabetes, and hyperlipidemia. And once again, obesity with exercise and weight loss helps modify all these other risk factors. Thank you very much for your attention, and thanks for inviting me. Thank you.
we have one more presentation. Luke, are you still here? Okay, there you go. Come on. Luke Bucket from the Terrell Fire Department is going to do a case presentation on a run that he was on. I asked him to do a presentation for.
All right, guys, I'm just doing a quick review about a run that we had. It's kind of, as far as patient care goes, is pretty normal, nothing out of the ordinary. But as far as the run goes, it was out of the ordinary. So that's why Barry asked us to take a look at it. So we were requested by Terrell Police Department for a standby for a male that went into his place of work, the KFC. I'm guessing you guys probably heard about this. He forced all the employees out at scissor point. So at 9:40 in the morning, THP received a phone call at 911 that man armed with scissors in KFC on the north end of Terre Haute. Initially, there were reports that there may be hostages or may not. It was kind of unknown at the time. So at 9:52, 12 minutes later, they called for us to stand by. Initially, it's kind of weird. We didn't get dispatched over the radio system. They ended up calling us, said, hey, did you guys get that? No, we didn't. But anyway, we got there a couple minutes later. It wasn't too far from station. So as the call progressed, they called for the SRT team. They called for a negotiator. They get there, set up a perimeter. They didn't want to go inside and just, force him out. Obviously, what's this guy up to? Does he want to do suicide by cop? Obviously, if they don't have to shoot him, they don't want to. They can end it peacefully. That was the whole objective. Because a lot of people ask, well, he just had scissors. Why didn't they just go in there and get him? Well, there's a lot more to it than just that. So the negotiator makes it on scene. They make contact with the subject, and he actually has a phone. He ended up calling his daughter at one point from while he was inside. And all of a sudden, probably about, about 2 hours, 15 minutes into the scene, we're still sitting there waiting for just seeing how this is evolving. They stop making contact with him. He stops responding to the negotiator. So they keep trying to make contact over the PA speaker of the SRT vehicle. They tell him, we're worried about you. You need to call us. You need to call us. So 30 minutes goes by. SRT team sent in a remote controlled robot to check on his well-being. So they didn't want to send an officer in there to provoke him if he was still alive. So they sent the robot in. They found him lying unresponsive on the floor of the kitchen. So SRT and TAC medics, they made entry into the structure, and after several minutes, we got called up. We were posted up outside after they cleared the building, made sure there were no more threats. We were able to walk in. So the only information that we had was that he was unresponsive. So we walk in at 12:45. We found TAC medics performing CPR on the patient at that time. It's unknown when he arrested. Like I said, they lost contact with him for about 30 minutes. So it could have been right at that 30-minute mark where he stabbed himself in the chest is what it appeared, or it could have been, 5 minutes. So he appeared to have a puncture wound just under the left nipple, approximately ½ an inch across. No external bleeding at all to approximate blood loss. He was still warm. No other noted injuries that we could see, just that small puncture wound to the left chest. So the decision was made to go ahead and work the patient, load him up in transport. We didn't work him on scene in the kitchen, obviously. Floor is dirty, it's greasy, it's slippery. It'd be a lot more work than just loading him up and getting him to our office. So we did have the monitor with us on scene. We did hook him up. We noticed that he was in PEA. So no pulse. We went ahead and continued CPR. So we packaged him onto a backboard, moved him to the cot, into the ambulance. So we made entry at 12:45. We got him out to the ambulance, got him intubated at 12:51. So 6 minutes? No issues there. CO2 of 40. Got an IO, epi. Called NIHRN, issued a trauma alert. So we went ahead and put a halo chest seal over that chest wound. And we also did a needle decompression on the left mid-clavicular, second intercostal space. So when we did that, it just got a few drops of blood out of there, nothing crazy, no air. So I'm guessing it was mostly a hemo than a pneumo. So throughout, he was PEA, no real big changes. We gave a second epi at 12:58 as we were pulling up to the ER. All subsequent pulse checks were, like I said, PA. So our timeline, we were dispatched at 9:51. We got there 57. On scene, that's when we actually pulled up to the building and we're getting ready to make entry. Got to him at 12:45. Intubated, IO, epi. Called the trauma alert a couple minutes later once we got the big things done. And then we got to Union just not very long later. So it was pretty quick. I mean, just from Lafayette and Fort Harrison to Union. So not a very far drive at all. So inside the restaurant, we spent 5 minutes. We were on scene for 8 minutes, almost 9. Transport was 4 minutes. And we were with this patient literally just under 13 minutes. So like I said, not a whole lot is, not a weird patient as far as treatment goes, but the whole situation being the standoff and him stabbing himself in the heart was pretty noteworthy. Any questions? Yes, sir.
I think you did a really good job managing. That's some complications. I think you through it. One, secured his airway, my airway. I like that you sealed where the bleeding was coming from, but then you also didn't forget to decompress, right? The pneumo, right? And if I end up being a hemothorax, but anytime there's penetrating injury in the chest cavity, you got to think about a tension pneumo, especially when they're pulses. Good job doing the needle decompression. And 13 minutes, you guys did that. Oh, that's amazing.
Well, and then we elaborate a little bit. You actually weren't the first medic in the door, right? You have a team.
No, the TAC medics, with the SRT, we have a team with SRT that works with THPD. You might be able to talk a little bit more about it, but they train with them. They make entries with them, I think. They do all their training with the SRT team so that they can go in and make entry into kind of a hot situation and not have to wait for a PD to secure it to where they know everything has been taken care of. So they can get to that patient and start treating them before it takes too long to actually make sure that all threats have been removed. So they did do a chest tube when we got to Union. I think they got about 250 cc's out of the chest. So, I mean, he bled a lot internally, obviously. Any other questions? Thank you.
All right, just a few things I want to go over before we conclude. One thing to keep in mind with the coronavirus, no, that's not with a Lyme, all right? The coronavirus, if there's any kind of flu-like symptoms or anything, please ask for travel. Ask those things that are necessary, the questions necessary, so we can stay protected in the field, stay protected at the hospitals when you bring the patients here. That's important. Another thing that was mentioned today in EMS advisory, I'm sure a couple things were actually mentioned. I think that you all know there's some new EMS scope of practice coming out for EMT level and advanced EMT level. We will be taking those into account and working on our protocols to adjust those. The state has adopted the full national scope of practice, period. Our medical directors are on board with the upgrades too for EMT and for paramedic, and there'll be some training, EMT and advanced EMT, and there'll be training and everything. And our goal is to potentially new protocols going in place April 1st. From that point on, and we'll work from there. One last thing to mention was if it's time for you to renew your stuff, I'm going to ask you guys, please take this back to anyone that you know. Absolutely do not hit the button to renew unless you have all your paperwork done and your signature signed. The state and the EMS commission has come up with an issue. There's a problem with that. If you don't have it ready, a fine is potential. Is that correct, Jeremy? So
It's a $500 fine.
$500 fine,
30-day suspension on your
certification.
And
and a 2-year probation. Yeah. So do not turn it in. Do not get anything. Just have it all completely signed, ready to go. So when you hit the button and you get audited, you can send it immediately. But don't have to run around then and get signatures and stuff. I'm just telling you guys for your own good. Do not put yourself in a position to be suspended and or on probation through the state, because that will never go well with you on your EMS stuff. So. Was that in last commission minutes? Yeah. They have not probably got the new ones online. Jason, we'll see what we can do about getting something for somebody. I'll see if Stan can get it to me. So, all right. Any other questions or anything for the good? Grab breakfast before you go. Thanks, guys. Appreciate it.